Hi everyone. Shujal, you want to kick us off and maybe share your screen and go through the agenda for everyone?
Yeah, I think we should wait, see if Dr. Bakian is there or Dr. Bakian is there. All right.
I think we can wait a few minutes.
Yeah, Dr. Georgie. 2 more minutes before we start. I'm waiting for Dr. Georgie to join. Just texted. See. Okay, should we start?
Yes. Go ahead.
All right, so thank you for joining everyone for the meeting today. We're gonna kick off this meeting by some great doctors who has joined this past week's Dr. Bakian, Dr. Georgie. Dr. Bakian is a periodontist, Dr. Georgie is endodontist, and also Dr. Jafari, who's working out in Santa Monica. So I hope, Dr. Jafari, you're here. So
Yes, I'm here.
welcome. So we'll start with quick introductions. You can take a few minutes, introduce yourself and where you've studied, how many experience you have, and some of the exciting stuff that you like to do. So, Dr. Bakian, you want to start first? And
Yeah, I could go first. Hi everyone, my name is Ara. I'm a new periodontist in the area. I went to Tufts for perio, and just this past June I graduated, and then I actually went to USC for dental school with Dr. Puri and Dr. Jafari here, and Dr. Gilbert. But I'm from Orange County, California, and you know, like to travel. I'm a big foodie, and that's pretty much it.
nice, welcome.
All right, welcome.
Thank you.
Dr. Jafari, you want to say a few words?
Sure, sure. I also graduated from USC as well. I graduated 2020. I now have 2 kids, so life is crazy. I would enjoy any time free that I have in my life.
Thank you. Welcome to Clove.
Thank you. Thank you so much.
Dr. Georgie, I think is going to be a little bit more until he joins us. But we can move on with our agenda for today. I also wanted to mention that we have our hygienist in the meeting as well today. So great stuff. And we also have all our regional managers in the meeting today as well. So it's going to be pretty exciting. Lots of things to learn. And we'll start off with some presentations from Dr. Josh, Dr. Bakayan, and yeah. So Dr. Bakayan, do you want to start with some of the things that you have for us?
Yeah, I could start. Let me share my screen. Okay, hopefully you guys can see this. Let me move my bar then. So I'm just gonna be going over like a few things, just because I know we're gonna be diving into osseous a little bit more. So I'll talk about that and some gingival grafts. And if we have time, I can. There's a couple other presentations on here or cases in here, but we'll see. So sorry, let me just minimize this or whatever. Okay. So yeah, basically osseous, right? A patient comes in, they have generalized bone loss or calculus, bleeding everywhere, pockets of 4, 5, 6 plus. And they go through a round of scaling, come back 4 to 6 weeks later, and they still have some pockets. There's still a little bit of bleeding, hopefully some improvement, but the pockets are still there. So kind of what we do at this point is referral to me, for example, and we would discuss with the patient something called osseous surgery. And the reason for this essentially is pocket reduction surgery. So what I like to tell my patients is that when the reason we're doing this is because one, those 5, 6, 7 millimeter pockets are difficult for the patient to clean. And then, theoretically, like a regular SRP won't get everything unless, you're amazing, you spent hours on it. So that's why they come to us and we tell them, hey, we need to open up, essentially the gums, clean out everything really well, the granulation tissue, any, calculus is left over in hopes of, reducing the pockets, because a 3 millimeter pocket is a lot easier for a patient to clean than a 6, 7 millimeter pocket. So this is kind of what we do, but there's also bone recontouring, but of course that whole logistics side to it was a conversation I'll have with them, because patients can get a little scared when you talk about, oh, you're going to remove my bone, things like that. But can you guys see the full screen by chance?
Yeah, we're good. Please
Yeah,
see
we
it.
can.
Okay. So this is a patient I had in dental school or residency. She came in, there's generalized recession, generalized attachment loss. She was like a 56-year-old smoker. So when you're doing your probings or whatnot, there's not a lot of bleeding, as you'll see in my perio chart a little bit later. But so she presented to me, and the first thing we did, we looked at her x-rays, generalized bone loss, her number 30, they extract it actually as we kind of go through. But here's their FMX, right? So looking at everything, right, there's a lot of generalized bone loss. There's vertical defects, horizontal defects, circumferential defects. There's calculus in a lot of areas, such as there. Some vertical defects, and then some circumferential defects. So when I look at a patient like this, right, there's a lot that's going on. One is the first thing, of course, we have to do is SRPs, right? That's the most important thing, because for me, we're not going to be able to do any type of surgery unless we have a clean plate. Essentially, you want everything to be very clean, or at least better than what patients presented to you, because the second you do any type of surgery, open up a gum, it's not going to be healing well at all. So for everyone, the most important thing is the SRPs and then maintenance as well, but then also very much emphasizing at-home care, because just because they leave, there's a 4 to 6 week period where they don't come back, or they come back for a reevaluation, and that is so key to seeing how things like improve or don't improve. So of course, if they don't improve, that's when they have to see me. But hopefully, the whole reason for the emphasis of the at-home care is because we want them to improve, because we want to make sure they don't lose these teeth, especially a lot of these ones for this patient where there's mobility, there's deep probing. So we'll kind of go into the pockets. So as you can kind of see here, there's, especially in the molars, there's some 5, 6, 7s, 8s. So those are a lot of areas that I'm really emphasizing with this patient here. And then same thing with the lower left side. There's some mobility on the teeth as well. And patients too, they get scared when the teeth start getting a little mobile. They're like, oh, am I at risk for losing my teeth? And yes, but we're able to maintain these teeth for honestly a very long time, hopefully, unless the bone loss is 60, 70, 80%. So I'm just going to kind of go through quadrant by quadrant. Honestly, I'll go quick, but as you can see here again, there's a lot of bone loss in this area. So and especially here, right, patients, like, how is the patient going to clean that? So the scaling, especially the initial scaling, is so important. But it's very, very difficult to do like an amazing job in this area, because it's just such a deep area. I mean, the probings don't show up, but on the PA you could see. So then here, right here too. So for a case like this, when I look at it, after the scaling, whatever, there's a vertical defect right there. So in a case like this, I would hopefully attempt to regenerate. So if for some reason you see vertical defects for a patient, always try to refer to me for any type of regeneration, because again, we could try to save these teeth. Yes, there's a deep probing in that area, or you can see this vertical defect, but we could attempt to regenerate. And then here as well. So number 12, you can see that circumferential defect. So on the upper left side too, what we'll be doing is osseous, but we'll also attempt to regenerate that area as well. Even though the mobility is a 2, right? I always tell my patients we could attempt to clean out really well, attempt to regenerate. It's not always a for sure thing, because especially with a 2 and the amount of bone loss this tooth can have, or a tooth has, I always tell patients, once we open up, clean super well, the amount of bone holding on could be a lot less than it shows. And what's holding the tooth right now is a lot of tissue. So if we clean out super well, clean everything out super well, there's a possibility that the tooth could be a little more mobile initially, but then hopefully at some point it will stabilize. So that's just something that I like to tell my patients, just because it is, there's pros and cons when you're doing any osseous or surgery for teeth that are already mobile. So same thing with the lower left side, osseous and regeneration.
So, Ara, if I can ask you a question?
Yeah, of course.
Or I can wait till you're done?
Totally up to you.
So, SRP is done, perio charting done, patient comes back in 6 weeks, we do another perio charting.
Yeah.
How much reduction of pockets are you expecting, and what should the hygienist look for?
So the ideal, right, is if the patient has 3s and 2s, always. That's always the ideal. Sometimes, if there's a 4 here and there, I'm not super worried. That wouldn't like warrant me a osseous right away. You could always maintain, see how patient's doing, because that 4 could easily turn to a 3. You know, if it's a 5 and a 6, that's when it's a little bit worrisome. And you know, not all the time when you do an SRP does it get better, right? It's all patient to patient. Hopefully, if they're doing a good job at home, they're a good OHI, then they'll get better. But not every patient will see a patient go from 6 or 7 to a 3. Does it make sense?
Okay, yep.
That's best case scenario, but you don't always see it, especially with patients like this, unless they're very ambitious or very forward about trying to save everything. It's hard to get a patient to change their habits overnight or even a 4 to 6 week span. So yeah, same thing with the anteriors. Nothing crazy. And so there's that. So of course, you know, we went through the scaling with this patient. 4 to 6 weeks come back. As you can see here, this patient didn't improve too much in my eyes. So you know, we're kind of just at this point, we talk to the patient, we tell her, hey, you need osseous surgery. And you know, that's what they'll come to me for. So, you know, for this patient, we did 3 quadrants to the lower right, lower right, excuse me. It wasn't too much of a concern for me. So we just went the other 3 quadrants. So essentially, I'm just going to go through the case here. But so what I like to do is I like to do these probing. So deep bone sounding is what it's called, to see like how deep this actually is. So of course, like for this 7s, patient's not going to be able to clean super well. So of course, we move forward with osseous surgery. And this is just a PA for the day, from that day. And here's just a view of the patient. So, you know, we open up the areas or open up the tissue. You know, there's always like different ways to do it. Intrasulcular incision, submarginal incision. I'm not going to go into that, but so we cut the tissue away, and this is the tissue that was taken off. And then this patient's a little different because they had this exostosis. So you don't usually see this. This is kind of an extreme case. So what we did essentially is we cut that whole buccal, that exostosis off. Because one, like at that point, you know, bacteria is stuck in that space between the bone and the tooth, which makes it actually impossible for the patient to clean. So we have to get rid of that. So remove the exostosis. And then here you could see, you know, we recontoured, I don't know if you could see that well, but between the premolar and the molar, you could see how it kind of contoured the bone like that. That's, you know, very ideal in my opinion. So what we try to do is just recontour the bone and then make a positive architecture is the goal of the surgery. So.
And then you're packing bone over there?
So in this case, I
defect?
didn't.
Yeah.
We usually now, depending on the area or the site, I would only put bone in areas that's like a contained defect. I'm not gonna just put bone on top of bone because it won't do anything. There's a contained defect, I'll put bone in those areas. Because it's, you know, it's like building on top of air. It doesn't work that way. So you have to have some sort of defect to be able to at least have that bone stable. So that's what, like earlier I was talking about, like the vertical defects or the circumferential defects help a lot, or like those are best case scenarios for regeneration. And then, you know, so we just close up. Oh, and something I was going to say is, you know, when I'm doing my consults, I'll tell the patients, hey, you know, when I open up, that could be areas when I'm cleaning out really well that I see a defect, and that's when I'll pack bone. So I'll always tell the patient like in advance that if we're going to use bone or not. And I'll decide the day of surgery or time of surgery. So we just close up, you know, so post-ops for me, just chlorhexidine and ibuprofen's enough. Unless I pack bone, I give them antibiotics as well. And for me, I don't like to do the full mouth ideally, just because you want the patient to eat on one side and then leave the other one half of the mouth to heal. Usually wait like a month and then do the other side.
I just want to follow up on the post-op photo. So I think as a doctor, as a general dentist, as well as a hygienist, we are kind of averse to flaps. We feel that they may be aggressive. If you don't mind going one more slide back. But this is the day of the surgery, the photo on the left. It's essentially, I mean, there's primary closure. It looks like it was not that intensive a surgery. It's called osseous surgery. It has a scary name,
Yeah.
but it looks like it was closed up very well. And then I guess your 2 week kind of confirms that.
Yeah. I mean, I wouldn't say, if you're doing like a like in this one honestly was a little difficult because of that exostosis, the bone. It's not like a super difficult, I would say, but like to do a really good one, it's a little time sensitive, or time, it takes a little bit of time to do a really good job to clean out super bowl, because as you know, granulation tissue takes forever to remove, like thoroughly. So that's probably the hardest part of it. The recontouring, I wouldn't say it's too difficult, but it's the cleaning out, and that's the most important part of osseous surgery. Just to clean everything out super, super well and create that architecture that is one, easier for the patient to clean. But at my post-op, you'll see kind of like the pros and cons of what of osseous surgery, because let's see here, this is a 2 week and this is a 3 month. So as you can imagine, right, there's already a lot of bone loss for this patient. And once you do osseous surgery, there's a couple things that could happen, right? You could see number 3, there's a lot more recession involved now. There's going to be some black triangles, of course, because you're essentially removing that interproximal bone for that architecture. And that's something that I always like to tell patients in advance, because aesthetically, yes, it doesn't look as good, but what's more important, the aesthetics, or trying to keep your teeth. So that's what I tell them. And like after I probe these are 3s, right? So that's the goal was achieved. And that's the whole point of osseous is pocket reduction surgery. Does it make sense?
Yeah, it makes sense.
Yeah. Okay.
So, Dr. Bakian, can we do gum grafting to
Yes.
for those recession areas?
Yeah, I was just about this. So there's 2 types of gum grafts. This is the first one. This is an FGG. So there's a lot of different reasons for it, right? Whether patients in ortho, the teeth are moving out of the buccal housing, patients are brushing really hard, clenching. There's a lot of different factors. But for this patient, for example, lower anteriors, you see there's a very thin amount of, keratinized tissue, and it's mostly mucosa. So of course, higher plaque accumulation. And what I like to tell my patients is there's not as much of a foundation for that tooth. So what we recommend for these is free gingival graft. And the hard part about this is the fact that patients don't have pain, right? So they're like, why do I need to do a surgery, or why do I need to do this what I have to do, why do I have to put myself in pain for anything, right? So for me, I just like to tell them that, like, one, it's a better foundation for your tooth, better plaque control, and once you start losing, once it's so thin that it's a lot easier to lose at that point. So I always like to tell patients that it's just better to have like a graft. So what we did is, we take the tooth from the palate, or you could take from a box, depending on your approach. And you'll put the graft at where it needs to be, just make sure it's very stable. And then you'll see that nice thick band of keratinized tissue. So I have a photo here kind of comparing the two. So of course, this is, you don't need this much KT around the teeth, but if you look at the before and after photo, we have a lot more KT around the teeth. The canine unfortunately did slough off. So there's a part of it, the piece of the graft that, died off, you could say. But we still got, at least a couple of millimeters underneath that canine, which is more than enough that works. Of course, ideally, you also try to do some sort of root coverage, but the whole point of FGG isn't for root coverage. It's for thickening the keratinized tissue. And in this case, too, this patient has so much clinical attachment loss that you can't tell them, like, oh, we're going to try to do root coverage too. And when for this patient, it's a lot more difficult and a lot less predictable. So our main goal is to increase that amount of KT.
Yeah,
Mhm.
that makes sense.
Yeah. And then the next one is connective tissue graft. Okay, so patient comes in, and a lot of the times, like patients will, or like, people will point out, oh, you have a recession here, recession here. For my kind of boundaries, if a patient has like 3 millimeters of recession, that's when I'll recommend a graft for them. If they have 1 millimeter recession and a good band of KT, the chances are it's not going to get that much worse over time, like, immediately. Over time, yeah, sure, if they're clenching a lot, brushing super hard, different. But for this patient, for example, if you look at the first premolar, there's a very thin band of KT in that area. So in a case like this, even though it's a very small amount of recession, I'd be like, okay, maybe we'll do a connective tissue graft. But then if you look at the second molar, that's 3 millimeters right there for me. So that's when I do recommend a connective tissue graft. And of course, there's a bunch of different approaches. There's a few different approaches to how to do it. But the whole point of connective tissue graft is to fix the recession. But you also thicken up the tissue. You don't thicken up the way that as FGG does, but you'll still thicken up your tissue. So I don't have any post-ops for this patient, unfortunately. But all we do is we open up the area, and the incision does matter in these cases. So it's not just open up a flap and put a graft there. So it's a little more technical. So we open up the flap, and then we place our graft on top of that, and then we close up. And this personally for me isn't the best surgery. Like I could be a lot cleaner for me, but it works. So that's pretty much that for grafting. When you're looking at teeth, again, like try not to be too aggressive. Because I had a patient come last week that was like, no one's said I needed a graft. They said I have some recession, but this is the first time I'm hearing that I need a graft now. And I always like to tell a patient, like, my parameters, if it's 3 millimeters or more, then yeah, absolutely. Like that's when I recommend it. It's not like you have to do it right away, but of course, over time, it can get worse. And the bad part about it is the recession's gaining, you're losing that buccal bone. And that's why you're getting that recession. If that makes sense. Because the lower it goes, that buccal bone is going lower and lower. And the lower it goes, the harder it is to do the connective tissue graft successfully, or to get 100% root coverage. So and then I have like some other cool cases you guys want to see, but up to you.
Yeah, sorry. This is a little bit sidetrack, but I have to get it out. Dr. Nisha or Irene, is this for gum grafting, is something that we can send in for approval for Medi-Cal or no?
I don't believe so.
Mm-mm.
It's considered elective, right? But at the end of the day, we can't, and I know you're not saying this, Shadral, but just in general, the treatment we recommend should be based on the clinical parameters, less so the insurance parameters. It does help to know what's covered and what's not, I'll be honest.
Right.
Things that are covered tend to be approved more. But as clinicians, whether you're a dentist or a hygienist, it's good to know that doctors like Dr. Bakian, Dr. Mara, they're there with us, right? So if you see this recession, we know somebody who can fix it, and their work is good. They've, everything's been vetted. I'm sure you guys have seen that. Or if you have noticed your pockets have improved, but not to the level of 4s and below, somebody who can provide that information to the patient. So it's not your job as a hygienist or as a dentist to necessarily tell them they need osseous surgery. What I do is I recommend them see the specialist. Hey, Mike, Jessica just did your SRPs, and your pockets are still higher than what I'd like them to be. I think it warrants a conversation with Dr. Bakian. who can go over other options of how we can reduce your pockets, to ensure that A, you can keep it clean, and B, you have a sterile oral cavity, just to ensure that you have a good long-term prognosis for your teeth as well as your gums. You say it like that, it tends to end up on the specialist consult. It's their decision if they want to proceed with treatment. A, they have to connect with the doctor. B, they have to see the urgency or need for the treatment, but it's their free will. The good news for us as being a part of Clove is that we have doctors. We know that the work can be done. There's nothing that we cannot do within our group.
Yeah.
Hi, Dr. Anish. Can I ask you a question?
Yes, hi.
Let's say if the patient is reluctant to go to a specialist or anything, do you still recommend going for arresting treatments or never?
Yeah, good question. Arrestin does work. It's been proven to work. There's research papers that say it works, but I do think that the patient would only be reluctant to get a consult with the doctor if I guess some barriers have been put up, whether that barrier is cost or over explaining the treatment of what osseous surgery is, right? I've heard some dentists explain that osseous surgery is flapping the gums, cutting it open, and then stitching it up. I guess in a crude sense of terms, that's true, but there's a lot more technicality to it. Dr. Puri Senior, do you have any thoughts on Arrestin?
Yeah, so Restin, if it is basically a soft tissue attachment loss or an isolated pocket where the tissue is inflamed, it's not going to do anything to the bone, but it definitely disinfects the pocket, and the patient has to maintain that with a good hygiene. It is a good interim medication. It is not a definitive solution to an osseous bone loss, really. So maybe you're kind of making it better for the time being and increasing the patient's awareness of it, but you have to monitor that as an adjunct treatment. You know, it's like debriding with a laser, putting them on chlorhexidine. These are good measures to do before you refer that patient back to the periodontist for maybe a surgical intervention, because surgical intervention is the last resort, really. It's not the first resort in most general dentist protocols. So you want to do non-surgical treatment, but in a very defined manner. So that's the way I do it. If I see isolated pockets which are really deep and bleeding, put them on chlorhexidine and do some Arrestin and get the patient back in 6 weeks or 3 months and follow up on that. And if the pockets are still bad, there's still attachment loss and deep pockets, bleeding and probing, refer them to a periodontist for a consultation. The patients will appreciate that, really. They all like to be taken care of. So, yeah. From a clinical point of view, from a legal point of view, I think periodontal disease has to be managed. There's no cure for it. You can treat it, but there's no cure. Unfortunately, that's a fact. What do you think, Dr. Bakian?
No,
Yeah.
that's very on point. And I kind of adds a thought that I wanted to say is, when patients come in for periodontal disease, I always tell them like, look, you're coming to see me as kind of a, we're trying to stop it from getting worse or progressing. So that's the whole point of what the osseous surgery essentially is. We're trying to stop the progression of periodontal disease, because the worse and worse it gets, of course, the harder it is, to save a tooth or whatnot. So the patients are always more reluctant to want to save it than just wait it out but everyone's a little different. So you'll see patients who are like, no, I don't want to do anything, and then just leave. And then, they'll come back in a couple of years and the tooth's in their hand.
Yeah, but at least you're covered clinically if you do all these protocols. You do the right thing clinically. And don't make the judgments for the patient. Let the patient decide. You have to just educate the patient and let them decide.
100%, I agree. And kind of going back to what Srijal was saying about coverage, osseous surgery, and Irene, if you don't mind, actually, Irene, do you want to explain the coverage for osseous surgery and how often it gets covered? I think she's muted.
She's not there, I think.
I think she stepped out. Okay, no worries. So osseous surgery for Denti-Cal, Medi-Cal patients is covered at 100% when it's accepted. And it's being accepted quite a bit right now. It's up to the periodontist to decide if he or she wants to do regenerative bone grafting with it, and that is an added cost for the patient, just like it is when we extract a tooth. Patient has to pay for bone graft, same idea, but we're getting a substantial amount of approvals for osseous surgery. So it is something that is, we're really rolling out and discussing. In terms of PPO coverage, high acceptance rate from PPOs. We've been submitting it to Delta Dental and a few other insurances, and it gets approved where the patient's copay is less than $100 per quad, and the insurance pays a substantial number. That the reason I'm explaining this is it really just puts into perspective how good it is. If insurance companies are approving it at a very, very high rate, it shows that it does work to prevent future tooth loss.
Okay, great. Great presentation, Ara.
Thank you.
Thank you, Dr. Bakian. And Dr. Bakian is happy to take implant cases as well.
Yeah, implant cases.
Surgical implant extractions, immediate implants, I'm sure, right?
Yeah, everything. Sinus lifts, GBRs,
Great.
you name it, I'll do it. So
Thank you.
yeah, of
Do
course.
any of the hygienists have any questions for Dr. Bakian?
No, everything was straightforward.
Okay,
Yeah,
great.
no
Awesome.
questions. Yeah.
Sweet. Of course.
Thanks, Jan.
Of course.
Thank you, Dr. Bakian. Those are some great case presentations, really interesting. Now I have Dr. Josh here. He's got some presentation or some tips. Lately, we've been getting a lot of requests from lab. They've been emailing us regarding the scans that the assistants do. So my request and recommendations to all the docs is to check your scans once the assistant scans the crowns or whatever the preps that you've done to eliminate the questionnaires that we sometimes get from the lab. So lately there has been a lot of requests, and that delays the production at the lab and eventually the delivery of the crowns.
So I think, Sujal, basically when we prep it, crown or a bridge or an implant impression, when we're writing a clinical lab notes, I think you should do that as all the docs rather than having your assistant put that in there, because a lot of times, the material choice or the design choice or the shade is your call, and it has to go out accurately. So it's a good idea to check the scan and check the notes before it goes out to the lab. We'll save so much of time on that. The lab has so many questions. A lot of times there's remakes and redos. Particularly the denture cases, the partial cases and the full denture cases. Please write accurate notes, what you need the patient to come back for, what you need the lab to do, and accurately reflect the due date, the delivery date. The lab does take at least a week, 10 days to, for every step. So I think that's so critical for all the docs to do it. And take these impressions, particularly the denture impressions. If you're scanning it, check the scan. If you're taking impressions, do the impressions yourself. But I've seen a lot of docs having an assistant do the arch impressions. And assistants are good and they will help, but I don't think they will do true justice to a partial impression or a full denture impression. So I think we need to get in there and get it done ourselves. They can take an opposing impression for us, but not the arch where you're building the prosthesis. And that's just my take. Yeah.
Yeah, thank you. I think Dr. Josh has also some good tips on it. He's been doing it at River Park, so he probably want to share a few things. Dr. Josh?
Yeah, I just wanted to touch on a few things that I've learned in my short career in terms of scanning and stuff like that. I'm sure we've all prepped a tooth that either has an existing crown or good anatomy already. And on our scanners, there's an option to click pre-prep scan. So almost for every case, I'm clicking this, having the assistant scan. Let's say we're doing tooth number 3. They're scanning, after I anesthetize, they're scanning upper right quad, lower right quad, and bite ahead of time. So the lab already has their existing bite with that tooth. And then the only thing you have to do is scan tooth number 3 after the prep. So you just delete there's a 4th scan view just for the prep. You delete tooth number 3 from that and then scan that. And then on my lab prescription, I'm saying, please copy contours and anatomy of tooth number 3 from pre-prep scan. Because the patient's already comfortable with the lingual contours that are there, the facial contours, all that, and the bite. And then it makes it simple for them. They just copy it and then mill it.
Yeah, that's a good point. Yeah.
So that was one thing. Another thing is that's super helpful, especially if you're prepping second molars, with second molars being the terminal hinge point in occlusion. Once you prep it, I'm sure you realize that your occlusal reduction is less than what you think you prepped. And that's because you lost the bite in a sense. So if you're doing that pre-prep scan for your second molars, then you're giving the lab where the bite was, not where it is after you've prepped. So that's another tip on that. Let me check my notes. There's one other thing. Oh, yes. I'm sure we've all had it where we do our occlusal reduction, we scan, and then we check the scan afterwards, and we're like, shoot, I only have 0.5 millimeters of occlusal reduction. If it's an RCT treated tooth, or even if it's a non-RCT treated tooth, you can ask the lab for a reduction coping. Let's say the patient already left. They send back the reduction coping that fits on the tooth, the model will show where they adjusted the tooth in the lab on the model, and then you put that coping on the tooth and adjust that same spot to the level of the reduction coping, and then the crown fits. I don't know if anyone's ever had experience with that.
Yeah. No, that's super helpful. Yes.
So just some tips that I came up with or came across throughout my years.
Those are great tips. I actually didn't know about the pre-op mode, so you and I can go through it together and send kind of like a screenshot manual of that. I think that sounds awesome. Sounds really good.
Yeah. The Panda has it. I haven't been able to find it on the Medit, but I also didn't spend a lot of time looking. I'm sure it has it.
But yeah, the Medit does have it. We did it
Okay.
a couple.
But yeah, super helpful. But if they're coming to you bombed out too, it's like it's helpful if they still have facial and lingual contours that you can use, but anatomy, it's kind of a wash.
Also, a good tip about the pre-op scans is if you're falling behind, you can have your assistant take care of it in the next room, and the patient feels like they're being taken care of rather than
Yep.
just sitting for X amount of time.
And also, I think for aesthetic cases where you're doing crowns or veneers or bridges, um, a pre-op scan actually is good handy for the lab. So they know exactly where the teeth are, how they're fitting, what you really want to do. If the patient has an existing anterior crown or a bridge and they are comfortable or you like the way it fits, they can copy that. Or you're doing some veneer cases or crown cases, multiple crown cases, do a pre-op scan on that. So the patient, the lab has it, and it's a lot easier for the lab to see what you're trying to improve. And I think the aesthetics will go up. And your finished cases will be better, for sure.
Definitely. And
Mhm.
a point on checking your scans after, I actually like to scan it myself because I know when there's heme or saliva on my prep. Assistants don't wear loops, so it's a lot harder for them to see if they actually got your margin or if they didn't. So I would recommend that, scanning it yourself. It takes a second, but obviously if you're super backed up, I understand, but definitely check it. Definitely check it.
Okay.
Thank you, docs. Those are some great tips.
Dr. Sorry, I should real quick.
Yeah.
Dr. Josh, you want to talk about the green Lido real quick?
Oh, sure. Green Lido is just 1 to 50,000 epi. If you're having trouble getting heme control around your prep, just do some PDL infiltrations around the tooth and it'll stop that heme. You could do that. So I don't know if any offices have the racemic pellets. They're like green pellets. You can soak that in hemodent and that gets good heme control too.
I started using the green Lido. Works amazing. Way better than
Yeah.
hemodent because hemodent leaves those black tags everywhere and your scanner does not like that.
Yeah.
So if you use the green Lido, patients already numb. They don't really feel it.
Yeah, just be careful with your hypertension patients and stuff like that.
Yeah.
All right. So I'll open the floor up right now. If anybody has any topics, cases, anything that they want to see, anything that they want to improve upon, before we get into clinical priorities and some of the major points.
I actually have a case. I have a patient that has he had a cleft lip, and there's a lot of bone loss around them. Or like, I mean, there's no number 7 or 8. It's just like a giant space. He's gone to Perio before, and they apparently weren't able to do something about it. But someone planned him for a bridge. And I don't really think it's not really the best option. There's so much so little bone around the teeth, around the cleft. I don't know who to send this to. Like, who would want to check this case out, because I feel like it needs like a prosthodontist, honestly. Hello? Sorry.
I know you're good. We can hear you. I'll
Yeah.
I know who the patient is. I will
Dr. Sagong?
I can either have the perio and I'll send it to all our specialists and we'll see what we come up with.
Everyone?
All of them.
All of them. Everyone in
Except
the
the
room.
endos. Except the
Okay.
endos. They don't need to be
Pediatric too. Okay. All right. Yeah. Thank you.
Thank you, doctor.
How old is the child, or how old is the patient?
He's
I don't
30.
remember. Oh, he's
I'm on his
30.
chart. I'm on his
Oh,
chart, 34.
yeah. Oh, really? Oh my gosh, I keep thinking he's like 25. Yeah, and never mind, he's not a child.
Mm.
Oops.
Okay.
Okay.
Yes,
Anyone else?
yes. I'll share my screen for his x-rays real quick so you guys can see it if you want. That's his number 6. You can see the large defect. Are you guys able to see my screen?
He's a really sweet guy. Like, he's
Yeah.
like addicted to Red Bull and I don't feel like he's gonna take care if I like place a bridge there, you know? And I don't know if that's gonna help him.
Yeah, I'll send it to some specialists and
Yeah.
That looks like a vertical, horizontal augmentation of the ridge, and I don't know how much you're gonna gain by doing all that.
Dr. Bakken, do you have any thoughts?
Well, if it wasn't a cleft lip patient, like the bony peaks kind of give you a estimate of how much you could gain. Yeah, you might not be able to get the entire thing, but the bony peaks is kind of your limit. So hopefully you're able to gain that much, if you did a really, really good job, but a little bit less. But with the cleft palate, I'd have to do some research on it and ask around. Because that could, I don't know how the tissue is, there's a lot of little factors that kind of go into this, especially with how close. Yeah, well, it's definitely a very big defect.
Also know he's financially not looking to spend much.
Yeah.
Okay, sounds good. Sujal?
All right, I'll go ahead and share my screen.
Hygienists, do you guys have any requests from us as doctors to make your life easier? Or have you seen ways we can improve?
You guys are doing great. I don't know. There's nothing I could think of.
No worries.
What about from us? Is there with referrals? Is everything okay with the notes and all that?
I think you guys are doing well. You're doing great. I just wanna kind of touch base that the hygienists are such an important part of the whole team. And the diagnosis starts with the hygienist. I know you guys are focused on perio, and because that's the main area of your expertise and focus. But don't forget the restorative part of it. Don't forget, you notice wear on the patient's teeth, malocclusion, open spaces, loose contacts. That also actually all affects perio. So, talk to the patient about that. Just ask him questions. Use intraoral pictures for restorative. If you see old filling, amalgam filling, or some wear aspects on the teeth, show that to the patient. Ask him questions, make notes, and then when you hand that over for the hygiene exam, feel free to let all that information known to the diagnosing doctor who's going to do the hygiene check, because they can pick up the thread what you start with the patient, whether it's ortho, is the patient interested in ortho, open contacts, wear, restorative. They can reinforce what you've already kind of spoken with the patient. So I think that the hygienists really do play a big role in initiating the diagnosis, initiating a dialogue with the patient. So in addition to the perio, just kind of, broaden your focus on the whole holistic part of dentistry.
I agree. I agree. Yesterday, Jessica spoke to one patient about osseous before I even walked in the room, and patient was asked me about it, which is always the best,
Yeah.
the best sign. Patient signed, made an appointment with Dr. Bakian. Then Jessica also spoke to a patient about braces. Patient wasn't interested in Invisalign. I walked in, she asked me about braces. I told her about Dr. Pizza. I'm sure Jessica spoke to her about Dr. Pizza as well. Patient signed up, put a deposit down to start braces. So that specific patient has so much crowding that she flosses 4 times a day and brushes 3 times a day, and she still has bleeding on almost every tooth, and she's just defeated at this point. So now that she's going to get ortho, her quality of life is going to improve greatly.
Yes.
Good job, Jessica.
That's awesome.
Real quick, I just wanted to remind everybody, Irene, are we going to talk about the justification form or leave it? Or I'm not sure what we decided on that.
Shujal has something, and then we'll go.
Oh, perfect. Thank
Unless
you.
Irene, did you already? Do you have what it?
I think we need to put it in place with our back end on that and roll it across each offices for that. I don't know if we have that ready to kind of briefly go over.
Yeah, Shujal, is it on your list, or should I go over it now?
You can go over it now.
Okay, guys. So for Denical, as you guys know, pre-auths are needed for almost everything, right? Crowns, removable, root canals, right? So major services. What we are noticing from the back end of these authorizations is that we are thinking that all partials are covered. They are not. So we need to, before we tell the patient we're going to send it out for authorization, there needs to be a little bit clarity in the doctor's mind. Is it going to be covered? Otherwise, A, we give them false hope, and then B, it's not done that day. Meaning sometimes the patients want to start the partial, right? So Denical has extremely stringent rules of when a partial is covered. For example, a cast metal partial is only covered when it's opposing a full complete denture, right? A resin partial is only covered when the patient is missing at least 4 posterior teeth. Is it? Yeah. So
Now,
it's a lot of,
posterior teeth, and I think it has to be an anterior tooth missing too.
exactly. So
In
it's
addition to that.
Yeah.
it's 4 posterior teeth plus an anterior tooth. So for us, there was a patient today that I saw. He said that the doctor said we're sending out for a partial, but he was only missing 2 molars, 14 and 15. It's not going to be approved, right? So I told him it's not going to be approved. But there's a lot of work, right? We have to do a justification form. I'm sure you guys have filled them out. B, our billing team has to send it. C, we get a rejection. Then we have to see why was it rejected. And then D, we have to call the patient and say, hey, it wasn't rejected. It's actually $1,500 or whatever the cost is, right? So there's a lot of steps that are unnecessary when from the start we should know it's not going to be covered. So I'll print that out just very simply and I want you guys to kind of research that because that's something we've noticed across the offices. Just kind of memorize it.
Yeah, I think we can pull together like the handbook, the guidelines on those kind of, like you said, for us to study it and during an exam and determine.
Yeah, exactly.
Put that simply in like bullet points. So everybody knows, the clinical staff, the doctors know it, and the front office people also know it.
Okay.
So that there is no unnecessary justification forms filled out, sent, denied. all that kind of stuff, so we can minimize all this non-productive consumption of time and effort. And if the patient is interested, a lot of times they're interested in getting the prosthesis started that day because it takes about a month or so from start to finish. So you can start the prosthesis the same day if the right correct information is shared with the patient. So I think it's important in the overall scheme of things,
Yeah.
right?
I think a lot of times too, the patients wait about, the response time a few weeks for them to only find out it was denied when they had some kind of hope that it was going to be covered. So I think hearing it up front clinically, if it's not going to be covered, we can let them know.
And if you're not sure, diagnose it, but say that, I mean, I tell the patient when it's covered or not covered because I'm kind of sure in my mind. But if you are not, you can say that, okay, let me check with my front office people and they can talk to you about that, about
And
the
then
coverage part,
at
right?
that time, you should go into the office and look at the bullet points that I'm going to give you guys.
Okay,
Just
yeah, I can refer
confirm.
that, yeah.
Because the front sometimes makes mistakes, right? Or your charting wasn't done of what teeth are missing or not.
I
Yeah.
see.
Yeah, we'll post it in the office, no problem. Okay, let me go ahead and share my screen. All right, I just want to go through some of the clinical priorities. I think some of these things we've discussed today, some of these things we've discussed in past meetings regarding documentation and compliance. Treatment plans are in open dental. Make sure we date stamp the notes. We need to take IOPs and photos on the same day. It helps with patient education, treatment acceptance. If you can, prioritize the treatment if in open dental. I know some of the doctors are already doing it, so thank you. It helps out so much at the front to put everything together and present that treatment plan and not make the patient wait too much. Perio protocols, 6 months perio charting is needed. It's required for the Medi-Cal for approvals for SRPs. Don't forget to always present irrigation. And also mark down bleeding recession as well in open dental. Educate your patients as well to all the hygienists and the doctors that these are some of the teeth that they had bleeding on. These are some of the teeth that you had recessions, so they are aware. Treatment standards, when you see large restorations, you know, it is suggestive to present or diagnose inlay, onlay, crowns, preferably EMAX. Make sure we do bone grafts before at the time of extractions, or at least collagen. Invisalign,
Sorry to
please.
interrupt, Shrujal.
Yeah.
Dr. Gilbert showed me a really good photo regarding bone grafts. That whenever the patient asks the importance of it, he actually shows this photo to them. So you can see it's very clear. Bone graft, or sorry, extraction without bone graft, very thin ridge. Extraction with bone graft, robust ridge. So we should start using more photos. I'm actually going to build this out, make sure I know we have models in every office of what a valplast is, what a bridge is, what a crown is, et cetera, et cetera. But I also am going to build out just a little pamphlet of photos like this, just to help you with explaining. I know a lot of doctors use YouTube, that's going great, but these photos are awesome too.
Yeah, everybody has TVs in the office, right? In each op. Yeah, just bring Google up and type in whatever you're trying to sell and just shit like bone graft versus no bone graft dental. And all these pictures will come up. Even like aesthetic cases, I always show like a front and you can see a big difference in those cases. Also the IOPs, I've seen some associates not showing pictures of stuff like their teeth. You guys are just saying, oh, you have a cavity, you need a filling, you need a crown on this tooth. Show them why they need a crown. Show that the tooth is cracking. Show that there's decay by the margin or something. It just goes a long way. A picture's worth 1,000 words. So it's a big selling point, those pictures.
So
Yeah,
something
definitely
else
visual
I do,
education.
yeah, patient education. Put it on the screen in front of them. They'll see it. It's very smart people, right? It's their mouth. They're aware of what it is. Same with the hygiene, right? Show them what the recession looks like. Show them what the inflamed gums look like. It goes a long way. And for the doctors, something that I do, there's no pressure to do it. But if I think that the patient was going to accept and they walk out without a follow-up appointment, I have my front team email them the IOP so that it's on their mind. And then they'll call back 100%. Because they know they need it.
Right.
Yeah, that's a good idea, Dr. Nish. Thank you. So yeah, Invisalign, please submit your prescription same day when the patient accepts the treatment. Usually I, email the doctors or, text the doctors to review the clean check as soon as it's approved. I'm usually on the website checking every day. So if you could please approve or review the clean check because, usually the patients are scheduled 3 weeks out. So if there's a delay in checking the clean check, then it delays the delivery of the trays. So please approve the clean checks right away. We usually request a down payment of $500 at the time of treatment acceptance from all patients. So yeah, hygiene and ortho, all hygienists, I would like to have you do a handoff to the doctor of all your findings. Make sure you've educated your patients before you're handing off to the doctor, so they're kind of aware of what's coming from the doctors as well. So it helps, doctor explain the treatments or diagnosis a little bit more efficiently. Promote sealants laser. It's available in some of the offices. Arrest and varnish night guards, and you have your bonus tied into that. So it's a great little side income that you can have.
Yeah, the sealants part, a lot of times we overlook sealants, particularly for, you can do sealants for preteens and teens and even young adults. If you see there's a propensity of, deep grooves and fissures and a lot of restorations and all, if you feel like, so sealants is a good preventative thing. And I think we overlook that in diagnosis and treatment planning. So I think that's something that the hygienist can help, and even the docs can look into that and diagnose it. You can
Yeah, and
do
sealants.
primarily molars, but you can even go premolars. There's no, if you see that there's a benefit, if there's deep grooves, you can do occlusal sealants on bicuspids too. There's no restriction. But to have a conversation with the patient or the patient's parents, if it's a young parent.
Yeah, for sealants, it is covered for all Medi-Cal patients up till the age of 21, right, Irene?
Correct.
Every 3 years.
And
Up till the age 22.
Yeah, technically 22. So 21 would still be covered.
So if they're 22, not covered.
If they're over 22, then it's not covered. Up
Yeah.
to 22.
Yeah. Okay, and for sedation and extractions, there is a Halcyon sedation log right on top of that lockbox where you find the Halcyon tablets.
Yeah, we need to log on to
Please
that
log.
Halcyon. Every patient we use Halcyon. This is mandatory from the pharmacy and DEA. If they audit us and we don't have a log, we're in trouble. So it's
Yeah.
the doctor's responsibility to make sure it's logged in.
Yeah. Operations and supplies. So if you're requesting any days off or you want your schedule changes, please go ahead and email admin, which is admin@clovedds.com. Any clinical questions, you can go ahead and email care@clovedds.com. And we have Clove whitening kits in our office. It's usually at the front. They're available if patients are interested. We have sonic toothbrushes. We have water flossers, and we also do in-office whitening, which is opalescence um, at a pretty good fee. So we can promote all these things to our patients as well.
Awesome. Something about the consents, sorry. We need to make sure these consents are being done before you inject the patient. Even if whether they're for SRPs or extractions or crown preps. When the patient checks in on that iPad, it automatically pulls up the consent and then they sign it at the front. I've noticed that a lot of our front team says, "Oh, I checked you in. Don't worry about it," because I understand patients don't love the iPad, but it works really well. And then your consent is not signed. And guess what? You're still doing a crown prep without even looking at it. So I see probably 10 to 20 a week across the offices of major services where the consent is not being signed. So go to the imaging tab, just double check it and protect yourself. And if you're doing same day treatment, make sure you get those consents, not just the treatment plan, but also the informed consent.
Can you, is there any way you can show that to everybody where the consents are in the imaging tab?
Sure. Give me one second.
But there has definitely been improvement. Some of the doctors are coming to me to ask me that, hey, the consents are signed, the treatment plans are signed, make sure they're signed. So
Good.
there's a good improvement in those areas.
Let me share my screen. It's right next to, it'll be right next to your medical history. So it should be under informed consent right here. So 826. And it not only should it have this, it should have the tooth number right here. So you should just double check. You don't even, I mean, you can open it if you want, but I don't even open it. I just see the date, 815 and 826 consent for crown. Then I know we're good.
Okay.
Some of the main pain points that we have, documentation, like we said, please enter your notes right away on the same day if possible. We talked about clinical justification, narrative, diagnosis, symptoms. Please write those things as well in your notes. If you use auto notes, it has all those things available. So use auto notes as much as possible. Perio protocol compliance, perio charting. Sometimes it's not being done. This is for the hygienist. Let's do perio charting every 6 months. It's a requirement. There has been missing diagnosis of bleeding and recession, lack of irrigation and resting follow-ups if the pockets are more than 5 millimeters. So let's improve upon those areas. Treatment plan weaknesses, large fillings are being diagnosed with direct restorations. Let's diagnose some inlays and onlays, crown if possible. Bone grafting. I'm not seeing a lot of bone grafting with extractions, especially Medi-Cal patients. So let's offer it to patients at the bare minimum, collagen. Invisalign prescriptions, we talked about it. Let's make some improvements on that. There are some specific Medi-Cal requirements. Medi-Cal requires period charting for approvals, especially SRPs. So, which is one of the reasons why it's very important for your new patients, doctors. If you see new patients and it's a Medi-Cal and even it's PPO, please do a period charting. It helps us approve SRPs. IOPs, again, very important for education, as we talked, for crown, onlays, inlays, and also for insurance authorization and getting claims approved. Hygiene productivity, missed opportunities. There has been some missed opportunities. There's a lot of room to diagnose SRPs if there is a significant bone loss. Yes, if the patients are under 21, 22, we can diagnose sealants. There are some opportunities for laser and arresting as well. So let's improve on those areas. Recall scheduling. There are certain offices that we're not scheduling recalls back. So I'll speak to front office in regards to those areas. But for hygienists, as you're bringing your patients at the front, please inform the front office that, hey, I want to see this patient back in 6 weeks, or I want to see this patient back in three months, and make sure the patients are scheduled before your end of the day. Check your patients, right? At the end of the day, make sure all those patients are scheduled. If they're not scheduled, let the front office know, hey, what happened with this patient, right? Why are they not scheduled? You can also call the patient back maybe next day and see if they want to schedule appointments with you. Hygiene to doctor handoffs on ortho days is important. And sedation extraction standards, as we talked, halcyon consent needs to be signed. We need to log the sedation logs. We need to check blood pressure. It is not documented every 5 minutes, especially when the patient is under sedation. So that's important. And extractions. So
I think that every 5 minutes is with IV sedation.
yeah. Okay, and that's all I had for today.
All right, great.
Anyone has any questions?
I did want to add to the scaling and route planning for Denti-Cal. So hygienist, if you're seeing your patient every 3 to 4 months, just remember Medi-Cal does cover an SRP every 24 months. So if you guys the patient had an SRP done 24 months ago, just keep in mind we can submit that back to Medi-Cal and see if they'll approve another SRP. So just keep that in mind when doing that.
I had a question about that too. Typically, after like a 2-year mark, like you stated, or 24 months, they'll stop covering the pair maintenance, right?
Correct.
I think that's then we see the need if we need to resend for another SRPs
Yes.
to keep them on the 3-month pair maintenance.
Correct. Yes.
Okay.
And we have been doing that at Prairie Dentistry. So
Is it a 3-month or 4-month, Irene?
well, they cover it every 3 to 4 months, but they'll only cover up to 24 months from the SRP date.
So
they won't
cover
keep paying perio maintenance forever.
8 cleanings after SRPs.
Mm-hmm.
Okay. Between 6 and 8. Okay.
So hygienists, just keep an eye out on that. Or in 24 months, like I said, we can submit another request for an SRP.
Okay, that's a good one. Thank you.
All right.
All right. Yeah.
Sorry, can I make a comment about x-rays?
Yes.
Can we make sure we have a PA of crown that we are about to prep? A lot of times I've seen crowns being treatment planned, but we don't have a PA of a tooth, especially if the tooth has a root canal previously. And also I've noticed some assistant miss the first premolars, and therefore, we miss cavities on those teeth. If we can remind the assistants to include the first premolars on their bite rings, that would be great.
No, so when you are, so let's say it's your patient and you're doing a prep on it and you see that the X-ray does not have a PA on it, I generally, if I see that patient, I tell my assistant to take a PA of that particular tooth. If you see that the bite wing don't have bicuspids on it, have them repeat it. So, you can take corrective action before you prep the tooth. Right, a lot of times I don't see PAs of that diagnosed tooth. So, but you're in control. You can always ask your staff to take the PA before you prep it.
Yeah, that's right. But sometimes the diagnosis or the treatment may change based on the PA.
Yeah, so before you touch the tooth, take a PA,
Okay.
confirm the diagnosis. If it is a change diagnosis, then have a discussion with the patient. But it's best to take a PA at the time of diagnosis. But I see that there's sometimes the PA is not there. You're right.
Yeah, okay.
Thank you, doctor. So if nobody has any questions, concern.
Sorry, I have one question.
Yeah.
If we are diagnosing Invisalign for patients, how do we go about doing that? Do we have an orthodontist we're working with, or what's the process of that?
Yeah, so if it's in Ventura County, Dr. Pizza is our orthodontist there. You guys are free to do the more simple cases with Invisalign. If it's a little more complex or it's not going the way you'd like it to go, Dr. Pizza's there to support us. If you're in the LA County area, same idea. You are free to do it as if you're comfortable doing it, but we are starting an orthodontist in the Santa Monica area. Dr. Waria, she'll be there on, I believe, September 18th. So she'll be there once a month. So
Oh, okay, great.
Yeah, and I moved the iTero from Sherman Oaks to Santa Monica today.
And then, for general dentists who are not comfortable doing Invisalign or easy ortho cases, I would suggest that you take some courses, do a workshop with Invisalign, and they will walk you through all the protocols. And it's actually a good thing to to understand that. Take some courses, get certified by Invisalign, so your confidence level will go up in diagnosis and treating, at least initially simpler cases. If it is a complicated case, yes, refer it to ortho. But I think this Invisalign, a lot of general dentists can handle it.
Okay, great. Thank you.
Yep.
All right, sounds good. Anyone else? Going once, twice, thrice. Okay. All right, so we'll end here. I think we had a great turnaround today. We had about 24, 25 people joining this meeting today, so it was really good. And I think the dinner is served, so let's end it here and you have a great night.
Are you serving dinner, Sujal?
You're welcome. Yes.
Okay. All right.
All right.
Thank
Thank you all. Have a
Thank
great
you
night.
all for coming. Yes.
Thanks for dinner.
Good night.
Thank you.
Bye.
Bye, guys.
Thank you. Bye-bye.
Bye.
Bye.
Good night.
Thank you.